pros and cons. Thorectomy, higher local recurrence. Extrapleural pneumonectomy, a little bit lower recurrence. Pleurectomy, decortication, we probably don't do as good a job at completely removing all of the tumor because the lung is still there and it's going to have some residual tumor probably, even low-level disease. Extrapleural pneumonectomy, we do a better job at completely removing the tumor. The pleurectomy is a safer operation. Extrapleural pneumonectomy is riskier. It is difficult to give effective radiation to patients who have undergone pleurectomy decortication. We are now investigating the possibility of doing a similar thing like we've done after with the extrapleural pneumonectomy of giving IMRT, and we're going to see how that goes. But after extrapleural pneumonectomy, we can give high-dose radiation very easily to the chest after we've taken the lung out. And again, this is something that I can that I'll be happy to share with Mesocare.Org and circulate it if you wish. But this is my rationale. This is how I approach patients now in my clinic. So they've met the initial requirements in terms of their breathing ability, and they've met the initial requirements in terms of their age and histologic type, et cetera. And we've done the surgical staging, and we don't think that they have metastatic disease someplace. Okay. If that patient is considered to be node negative, meaning that I did not find any lymph glands that had metastatic tumor on them when I did the endobronchial ultrasound or the mediastinoscopy, then what I do is I bring them to surgery with the plan of doing an extrapleural pneumonectomy. We mobilize the entire lung, like you saw in the videos, and then I biopsy additional lymph glands, and I send those off to our pathologists who looks at them while the patient is still asleep. And if the patient does not have lymph glands that are involved, then I will go ahead and remove his lung. If I find that the patient's got lymph glands, at that point I make a decision to do the extrapleural pneumonectomy, because I don't believe that an extrapleural pneumonectomy is usually all that effective in patients who have tumor that goes to the lymph glands. Conversely, if patients have the staging studies and we find that they have those lymph glands involved, depending on how young the patient is and how good their performance status is and how extensive their disease is, I will either give them chemotherapy and then consider doing an operation, or I will just treat those patients with chemotherapy alone. And clearly, patients who undergo the surgical staging and are found to have metastatic disease, then those patients usually undergo just chemotherapy. We don't operate on those patients. So in conclusion, the optimal management, especially surgical management for this disease, remains controversial. In the group of patients who have epithelioid tumors who don't have lymph glands involved, multimodality therapy with an extrapleural pneumonectomy, chemotherapy, and radiation is probably a reasonable thing. However, that is as yet unproven. The goal of any cytoreductive surgery, whether it's extrapleural pneumonectomy or pleurectomy decortication, should be to completely remove all microscopic disease. And lastly, after extrapleural pneumonectomy, although we don't have randomized data to show this, the majority of studies that have looked at it suggest that high-dose radiation, at least over 45 Gray, appears to be effective in controlling disease and preventing local recurrence. And unfortunately, distant failure still is an issue. We need better chemotherapeutic agents. We need novel therapies like immunotherapies, I think, if we're going to significantly impact this disease in the future. So with that, I'd like to thank Mesocare.Org for inviting me here today, and happy to answer any questions.